are in the bladder, the rectum, the external sphincter, and in the nerves that give you an erection. Where are all those structures? They're within millimeters of the prostate. Every one of those is within millimeters of the prostate. If you use protons, yes, you've got a superior beam, but it's fuzzy. It's accurate to 5 millimeters, 7 millimeters, 8 millimeters. So they still have to build that margin. They still have to build the margin, and they still protract the dose over weeks. Why? Because they don't want to burn the bladder and the rectum. And what dose do they give? They give this exact dose as IMRT. They don't give any more radiation. So the cure rates are not going to be any different than IMRT. So now I'm biased because it's my machine, and I've done all the research on this, but the Cyberknife is better. Now, why do they treat, if prostate cancer, if protons are identical to IMRT in terms of dosing and dose distribution and outcomes, why do they advertise so much to treat protons? Do you know what that center costs? It was $200 million. The first investors already went bankrupt. So you can, protons are great for certain applications. They're no question the best application for example, treating a pediatric patient where you want to treat the spine from a pediatric malignancy. You do not want to treat the vertebral bodies because you will stunt the child's growth the rest of his life. Protons, no question, is better. Another application is uveal melanoma. Melanoma in your retina, or you don't want to hit the part of the retina where most of your vision is. So protons are great for that. Best treatment available. But you can't support a center that costs $200 million by treating pediatric malignancies and melanomas and these fascinoma cases. You need a diagnosis where there's lots and lots of patients. Prostate's perfect. So you can charge twice as much as IMRT. So proton centers keep themselves alive by treating patients with prostate cancer, charging them a fortune, and paying for a team of 7 physicists to keep the damn machine running. So I think it's identical to IMRT for treatment, and I think it's inferior to Cyberknife.
How was Cyberknife with that same argument, and I understood it completely, and it makes sense. But how does Cyberknife then compare to IMRT for cost? And
it's cheaper.
It's cheaper.
It's cheaper.
So with what you showed, how come it's not the standard of care then?
Well,
why isn't it the first choice that?
No, it's not.
The side effects are less. It seems like it would be the first choice if I wanted radiation.
Yeah. So why is it not standard of care? Because there are no randomized trials comparing Cyberknife to IMRT. So you can look at my study, and I can show you the toxicity, and you can look at Memorial Sloan Kettering's. You can look at the two, and you say, well, it looks better. You know, it's got to look a little better, but it wasn't a randomized trial, so it's not definitive. It's probably better. And if you're a department head and you're running a radiation department, and you make twice as much money for protracting your treatment over 8 weeks, and you're dying versus doing it 5 fractions, 1 week, doing it 1 week, and you're not 100% certain it's better. You think it's probably better, but you think, well, you don't know for sure. What are you going to do? You're going to keep doing the stuff that makes you more money.
Yeah.
All of the money.
And the survival rates, at least right now, they look about the same for all these radiation treatments. Is that correct?
Yeah, so the problem with prostate cancer is so few people die from it that it's really hard to show differences in survival. So it's very difficult. And so to show a difference in survival between IMRT and Cyberknife, you're going to have 1,000 patients in this study, flip a coin, and you're going to fall in for 20 years. And that's not going to happen in my lifetime.
Isn't your selling point, though, you've got a highly accurate procedure and there's less collateral damage?
Correct.
So
Yeah.
that's your selling point.
Yeah.
And so how do you know that you've done well after you've done your work? The PSA test, right? And what else do you use? That
PSA, that's it.
That's it?
Yep.
Okay.
So I'm just submitted for Astra for our meeting, along with another investigator, our combined results on this. And we looked at a 10-year average PSA
Right.
following Cyberknife.
Right.
The median PSA, 10 years following treatment, is 0.1.
Right.
Extremely low. You don't see those levels with IMRT or protons.
Yeah.
So we do a better job of ablating cancer. If you look at, that was those curves that I showed you. Remember we said 97%.
Right.
That is watching PSA and then determining, did the PSA go back up?
Okay.
If the PSA went back up, that's a failure.
Okay.
So that's what we use.
Thank you.
With prostate cancer affecting everybody in the world, what's the life expectancy of prostate cancer not being here anymore? 50 years, 100 years?
Well, so we know that human cells, when we get old, the cells become old and they start doing crazy things. They quit dividing the way they're supposed to, right? Because you think about your lifetime, these cells in the prostate, in your skin, in your lungs, they've had not millions, but probably hundreds of thousands of divisions throughout, when somebody turns 80, right? They've had so many divisions and every time they have to divide and make an exact replica of themselves, right? Well, eventually that starts not working, and you start getting problems in the genes. And the genes start not working right, and then they start growing out of control. Well, this is part of getting old. And so when will we be able to prevent prostate? I mean, if you look at 80-year-old guys and they died of a heart attack, you take the prostate out, nearly all of them have some prostate cancer. They didn't know it. So when will we figure this out? Well, I don't know, but it's going to take a long time for us to come up with methodologies to reverse problems in the fidelity of cell divisions. I think our biology is not close to doing that yet. So it's going to take a while.
Because when you're diagnosed, you're given options. And I got a book that was given to me of all the different things you do. And Cyberknife wasn't in there yet.
No.
And the first thing they said was the seeds. Put the seeds in and do it that way. But it was contained in my prostate. So I could have done an external beam or...
You could have. Or surgery.
Or surgery. And I had mine taken out and eliminated all the other choices that I could have had. But now I have the option of even being observing, even though I had a 7. Gleason 7, they still said that if you want to, we can go ahead and let you observe. But I checked it out.
Yeah, I think that's
I
smart.
wanted to know.
For a Gleason 7, I think you made the right choice. And surgery's a good option. Surgery, nothing wrong with surgery. It's very effective. You got a question?
Yeah, testosterone, losing energy of 82. What do you think about supplements?
Have you had prostate cancer?
Yeah,
How long ago?
06.
Oh, 06. So you are 14 years out.
Yeah.
You're treated with surgery?
Yes, radical.
And your PSA is undetectable?
Undetectable.
I think it's okay.
Okay, I'm glad you hear
Yeah. 14 years is a long time. Yes, ma'am.
What do you think about the idea that they don't really like to do the PSAs after 70? They don't think it's necessary.
Well, so again, see, these public health doctors and epidemiologists look at what's the likelihood that treatment's going to really benefit you. And it becomes, after age 70, the probable benefit from screening drops. So I think it depends on how healthy you are. So if you have someone who is got a lot of other medical problems at age 70, probably it's reasonable to quit looking. But if you're pretty healthy
Yeah.
and you think you're going to live for 10 years or more,
If you think you probably are.
well, that would
You're
depend on the
healthy.
person.
Yeah.
Again, if you have 1 foot in the grave, well,
Yeah.
don't do it. But I mean, I gave the anecdote about my uncle.
Yeah.
He was 80 and he lived to be 98. I can guarantee you he would have died within 10 years. He would have died 10 years younger. If he we had that screen at PSA.
Yeah.
Yes, sir.
You mentioned in development that the problem you have with the prostrate is the prostrate moves,
Yes.
and you had to develop tools and stuff to take that into account. When you metastasize, do they move? Metastasize points?
Oh, good question. It depends. Depends on where the lymph nodes are, or if it's in bone, the Cyberknife can lock on gold markers, as I
Okay,
showed you.
okay.
That's how we treat the prostate. We put gold markers in it, and we lock on those, and we move with the markers.
Okay.
But when it goes to bone, the Cyberknife can lock on. It
Okay.
sees it, it locks on it, and so it's not a problem. If the patient's on the table and he sneezes, it's okay. It'll see it, and it'll fix it. Lymph nodes usually are close to bone. But if the lymph node is floating in the breeze, like a pararectal lymph node, it's right next to the rectum. That doesn't happen very often, but if they are, we need to put markers in it. But I think 90% of the time, a lymph node is close enough to bone that we could, like that one I showed you.
Yes.
We didn't lock on that lymph node. We locked on the bone, the spine, that was only a centimeter away.
I see.
And the amount of motion at that distance is quite minimal. Now, when there is motion, though, in the lymph nodes, it tends to be up and down. Because when you breathe, your diaphragms come up and down, and the lymph nodes can go up and down with it. So when we target with the Cyberknife, we take an image with the patient breathing out and breathing in, and then we treat the full extent of the excursion of the lymph node during the breathing cycle. It's usually not very much. Down the pelvis, it's 0. But if you're up by the kidneys, it's sometimes a lymph node might move by 5, 7, 8 millimeters. That's okay. We just treat the full excursion.
What's the satisfaction rate of your
Amazing,
patient
isn't it, to
Cyberknife?
track all of that?
In other words, out of 100, how many are satisfied 5 years, 4 years later that they chose Cyberknife?
Well, I haven't asked that specific question, so I don't know for sure. But